Good afternoon. I would like to thank the organizers for giving me the opportunity to present to you today, improving outcomes in BRCA-associated breast cancers. Specifically, what I would like to do today within the next 20 minutes, give you an overview of the recent advances related to the management of patients with BRCA-related breast cancer. I will be talking about briefly background BRCA-related breast cancer, and then dive into the new data related to platinums, as well as Parp inhibitors related to mechanism of action in the metastatic setting. I will touch base on resistance and just briefly mentioned other gene indications and other agents. I had summarized a lot of data during the previous meetings with BGICC, so I will be focusing on most recent updates for this talk. Needless to say, this is, I think, a pie chart that everybody is familiar with. About 5 to 10% of all breast cancers are related to germline mutations in high to moderate penetrant genes, and about 85% are due to germline mutations in BRCA1 and 2. The second part here are breast cancers due to gene mutations in low penetrant genes, for example, CHEK2 mutations. And then the rest is what we call sporadic breast cancer that are most probably related to mutations in high frequency alleles, single nucleotide polymorphisms, and there are potential interactions with the environment. For example, estrogen use would be one example. BRCA-related breast cancers are known to be high grade, especially for BRCA1. ER negativity is about 70%, and about 40 to 60% of BRCA1 mutation carriers develop triple negative breast cancer. And when we look at all of our triple negative breast cancer patients and do BRCA testing, their positivity rate is anywhere between 11 and 37%. In our series, it was for patients diagnosed under age 40 with triple negative breast cancer, even if they did not have a family history, about 23%. Just one or two slides about how do BRCA positive patients respond to standard therapies with taxanes and anthracyclines. Here we looked at the data, patients receiving neoadjuvant chemotherapy with and without mutations. The chemotherapy was our institutional standard, taxanes and anthracyclines. About 90% of the patients had received that. And what we have shown is that, very interestingly, the complete pathologic response rate in BRCA1 mutation carriers was 46%, and in the negatives, 22.4%. And and this is in lines with the literature, what was reported for anthracyclines and taxanes in the neoadjuvant setting. But the question is whether we can improve on the outcome for BRCA mutation carriers if we add, for example, platinums and Parp inhibitors. And indeed, I want to start with data and updated data related to the platinums. Now, in the metastatic setting, we really don't have a lot of updated data. You all are familiar with the TNT phase 3 carboplatinum versus docetaxel study in metastatic triple negative breast cancer, or BRCA1 and 2 mutation carriers. In the study, close to 400 patients were randomized to carboplatinum and docetaxel, and they were staged every 2 cycles until progression or disease toxicity. The objective response rate, as you can see, was not different for both arms, the platinums and docetaxel, about 31 and 34%. However, when they looked at germline BRCA1 and 2 mutation carriers, platinum response rate was significantly higher. As you can see here, 68% response rate compared to 33% with docetaxel. This difference was only seen in germline mutation carriers, not in patients who've had a tumor somatic BRCA mutation. And this is the update that was published now almost two years ago. Again, when they looked at the whole population, the disease-free survival was not different for patients who received platinum versus docetaxel. But again, when you look at the germline mutation carriers, patients with the germline mutation had a better response, had a better disease-free survival when they were treated with platinum versus docetaxel. And again, having a BRCA mutation in the tumors, a somatic mutation, did not make a difference in terms of disease-free survival. Now, I want to now talk about a very recent study that was published just literally a few months ago by Nadine Tang. She had presented it also at the San Antonio conference, and this was the first and only study looking in the neoadjuvant setting at platinums versus anthracyclines. In the study, patients with germline mutations who had HER2-negative breast cancer, tumor greater than 1.5 centimeters, regardless lymph node status, underwent a baseline biopsy for research and then randomized to, in the neoadjuvant setting, to cisplatin at this dose every 3 weeks, or AC standard 60 and 600 every 3 weeks, and then proceeded with surgery. The primary endpoint was pathologic complete response rate and residual tumor burden. The stratification factors were ER positive versus negativity, and also recruitment site, as this was a multi-institutional study. After surgery, adjuvant therapy was per provider. Patients could have received taxanes if they were on this arm, or if they were on the cisplatin arm, they could have received AC and/or taxanes. And when we look at the complete pathologic response rate, you can see the blue bars is for platinums and the red bar is for AC. Statistically, numerically there was, but statistically there was no difference. So unlike the investigators expected, treating germline positive patients with platinums here in the blue bar did not induce a higher PCR rate. And when they looked at the residual cancer burden also, and again, there was no difference in terms of residual cancer burden in these patients with BRCA mutations, whether they received AC, or platinums. And when they looked at some subgroups, again, hoping that maybe some of the subgroup analysis would show a benefit for cisplatin by age, by BRCA1 and 2 status, by nodal status, lymphocyte infiltrate, or hormone receptor status, so ER positive, negative. There was really no difference in terms of responding to AC versus platinum in the neoadjuvant setting. Now, that is basically all the data we have for in the neoadjuvant setting in terms of a prospective study for the platinums. How about Parp inhibitors? Now, you all know this, that in a normal cell, when there's DNA damage, cells are repaired by homologous recombination and base excision repair, and the cell survives. If there's BRCA loss, then the homologous recombination is defective, but BER is functional, so the cell is viable. If the cell is Parp deficient, then the BER is not functional, but the homologous recombination is functional. But if you treat a patient who has a BRCA loss, such as germline mutations, with a Parp inhibitor, then you basically block both of these pathways, and there's then the endpoint and outcome is synthetic lethality. And now I want to summarize the 3 prospective trials, large metastatic setting trials with 3 Parp inhibitors: Olympia-D with olaparib, Brocade-3 with veliparib, and Ambraka with talazoparib. So I will start chronologically. The first study that was reported is the Olympia-D study comparing olaparib versus chemotherapy of physician choice in metastatic breast cancer patients who have germline positive disease and are HER2 negative. Patients were randomized in a 2-to-1 fashion. Primary endpoint was progression-free survival, and secondary endpoint was overall survival objective response rate. When we look at the primary endpoint, the progression-free survival was statistically significantly longer, 7 months versus 4.2 months for the olaparib arm versus standard chemotherapy. That was statistically significant. So the progression-free survival was improved by about 42%. However, and this was, the progression-free survival was published in New England Journal in 2017, but very recently, the final overall survival was published in 2019 by Mark Robson, there was no difference. So the overall survival was not different. The objective response rate, which was a secondary endpoint, as you can see, doubled. So chemotherapy was 30%, olaparib induced a 60% objective response rate that was statistically significant. The second study is the Ambraka study. I'm not going to go through the design. It's very similar. Patients were randomized to talazoparib, the other oral Parp inhibitor, versus a physician choice of chemotherapy, metastatic breast cancer, germline positive, HER2 negative. Again, primary endpoint was progression-free survival, and secondary endpoints overall survival and objective response rate. Very similar to the Olympia-A study, the progression-free survival was statistically significantly longer, from 5.6 to 8.6 months. Again, 3 months different, very similar. And the hazard ratio, very similar also, 46%, as you can see here. However, a recent publication just a few months ago showed that the overall survival was not different between the talazoparib arm and the chemotherapy arm. Again, similar to the Olympia-D study. The objective response rate was again similar to the Olympia-D study. Response rate improved from 28% to 60%. The other one was 29% and 60%. So very similar. We see some side effects with the olaparib. When we look at grade 3 with the, talazoparib, anemia was 38%. Thrombocytopenia rate was 11%. So kind of bone marrow suppression, a little bit more than the olaparib. The third study is the one we published with Veronique Diarras very recently, just a few months ago in Lancet Oncology. That is a little bit different than the other study. Here we combined the chemotherapy with carboplatinum and paclitaxel compared to paclitaxel alone. So there is no mono Parp inhibitor arm, the BRCA3. And here again, the patient population, germline BRCA 1 and 2 positive, HER2 negative, metastatic breast cancer. And again, patients were randomized to carbotaxol versus carbotaxol and the Parp inhibitor veliparib. In a 2-to-1 randomization, a little bit more than 500 patients. The primary endpoint was progression-free survival. The secondary endpoint was objective response rate and overall survival, very similar to the other study. Initially, we reported the results at ESMO, and then as I mentioned, we published it in Lancet Oncology. Patients who were treated with the additional Parp inhibitor veliparib had a significantly prolonged progression-free survival. In fact, at 2 years, the survival was 44% for patients on the veliparib arm versus 27% for the chemo arm, and at 3 years, so there is a sustained response. The progression, 37% of the patients were progression-free versus 20% on the chemo arm, and the median progression-free survival improved by more than 6 months. So it's a little bit longer than, actually double the longer than the previous 2 studies. When we look at the blinded monotherapy arm, because patients were allowed to cross over to monotherapy, you can see here that the side effects were really minimal. In fact, anemia was only 3%, which was 40% in the other trial, and thrombocytopenia 2%, which was 11% in the talazoparib study. We also looked and presented at San Antonio the pre-planned analysis in patients who received it as first line. There was a statistically significant prolongation in progression-free survival in especially patients who received this as first-line metastatic breast cancer. You can see here the improvement was about 7 months. Basically, patients were progression-free for the median time was close to 2 years. I now want to briefly, within the last few minutes, talk about an important clinical aspect that we will be facing very soon now that Parp inhibitors have become standard of care, Parp inhibitor in resistance. So about 50% of the patients do not respond to Parp inhibitors, and further 50% that initially responded eventually progress. So can we prevent or delay Parp inhibitor resistance? I'm not going to go through this in detail, but the Parp inhibitor resistant mechanism is really not very well known. These are the proposed preclinical mechanisms. Prospective trials are ongoing. For example, there could be restoration of BRCA1 and 2 function, loss of some 53BP1 expression, loss of Parp expression. So we really don't know what the mechanism is. And in fact, we at our institution have a study, we call it the Brc Octopus Trial, that just started trying to overcome Parp inhibitor resistance. It's a multi-arm study. We started with one arm so far, where we are treating Parp inhibitor resistance patients with the Parp inhibitor and ATR inhibitor. But other agents are also very important, such as VEGF inhibitor, c-MET inhibitors, and V1 inhibitors. And we built in biomarkers to understand mechanism of resistance of DNA damage, hypoxia markers, VEGF levels, circulating tumor DNA, to look at some reversion mutations in the BRCA. And hopefully next year I can give you some of the results. And finally, how about breast cancer and other mutations in homologous recombination related genes? And there's this one study that Nadine Tang just published, very small study, but I wanted to mention that in this phase 2 study, there were two cohorts, one patients with germline mutations, these are the germline mutations, but not BRCA, and the other cohort with somatic mutations, including BRCA, but tumor-related mutations. All of these patients were treated with olaparib, and then tumor response was evaluated. In cohort 1, there were all of these germline mutations. A lot of patients had PALB2, and in the somatic cohort, 15 patients had BRCA somatic mutations, and this is the rest. And when we look at the results in cohort 1 for germline, there was a 33% response rate, but that was only PALB2 mutation carriers. In the second cohort, there was a 31%, but that was only patients who had a tumor somatic mutation, not germline, but tumor. And the authors concluded that the objective response rate is significant for patients who have a tumor BRCA mutation, not germline, because they were excluded. And then in terms of germline, only patients with PALB2 mutations had a response. No other responses were seen in other hereditary breast cancer genes such as ATM, CHEK2, and others. So there's one study now ongoing with olaparib in germline PALB2 mutation carriers. So hopefully we'll have some results next year. So in conclusion, in the neoadjuvant setting for BRCA positive patients, Parp inhibitors, there is a randomized phase 2 clinical trial ongoing. So right now it's not standard of care. And we also have now data from the INFORM trial that I mentioned to you. Platinums are as effective as anthracyclines. And if you wanted to avoid anthracyclines, you could use the platinums. Based on this study. In the adjuvant setting, the Olympia A study that is randomizing patients to adjuvant Parp inhibitor for a year versus placebo is ongoing, so we don't have the results. In the metastatic setting for BRCA mutation carriers, Parp inhibitors are now standard of care. You can use it first line and afterwards. There is also now data from the BRCA3 trial that if you combine Parp inhibitors with carbotaxol, it's better than chemo. The response rate is 76%, very high. We do have some remaining questions though. For example, there is no study looking at Parp inhibitor versus Parp inhibitor and carbo. So the Parp alone arm is not there. And I think Parp inhibitor plus carbo followed by Parp inhibitor, that is a very valid question. We have to figure out how to prevent Parp inhibitor resistance, such as different agents. I had mentioned to you ATR inhibitors, PD-L1, V1 inhibitors. And then finally, how about the other genes? We, for years, have talked about BRCA1 and 2, but now we have other gene mutation carriers, PALB2. And based on the small study I have shown you, there is a significant response rate in patients with PALB2 mutations when they are treated with Parp inhibitors, olaparib. So that's a very interesting area of research. So with this, I would like to conclude and thank you very much for your attention. Thank you.